back to our morning classes. We'll continue with the discussion of ECG. So, just to recap, we discussed how we actually evaluate the ECG, what are the things which we need to look at, and based on that, how do we come to a diagnosis. And we also gave a brief overview of how we decide about the issues related to ischemia, infarction, because that is the most important thing which you should tend to diagnose in a patient who has a normal ECG. And also, what are the situations in which the patient doesn't have a MI, but it might be mistaken for a MI. Now, having said that, we'll just take you through some interesting ECGs. And the way it is made is it needs to be an interactive session. So any one of you can just unmute yourself and then start talking about the ECG. So this is the first ECG. Who would like to tell about this ECG?
Looks like lead misplacement.
Again, what is important is to follow the order. Okay, so if you look at this particular ECG, you can see that L1 is totally negative and P wave is totally negative. And AVR, you have the P wave which is positive and the QRS complex which is positive. If you look from V1 to V6, you can see that there is a normal progression of the R wave, though probably the leads are not placed very well. They are still equiphasic by V6, but overall, the R wave is smaller in V1 and it's increasing in size by V6. So when you have this type of a ECG, what are the differential diagnoses on there? One you said is lead misplacement. So lead misplacement is typically the arm leads. So people, the easy way of remembering is R for R. That is, right arm should be red in color. Generally, they will tend to reverse it. So if the right arm is put on the left arm, the lead is put on the left arm, then L1 becomes AVR and AVR becomes L1. So it becomes exactly opposite. So we told that in AVR, all the leads are negative. That is, all the waves are negative. That is, P is negative, QRS is negative. And in AVL, all are positive. So P wave is positive and QRS complex is positive. So the lateral, that is L1 lead reversal, will produce this type of a situation where the P wave is negative, QRS is negative, P wave is positive, and QRS is positive. Okay, so that is suggestive of lead reversal. So now the question is, why can't this be a dextrocardia? So the heart is now on the right side. So that's the reason why you are having this type of a ECG where L1 is negative and AVR is positive. Amir?
Sir, the R wave progression is in the reverse direction, sir, in the chest leads. And in the limb leads, there will be negative QRS complex, including P waves and T waves, sir.
So when we say dextrocardia, that means the heart instead of left side, it is on the right side. So all the leads will be reversed. We said that chest leads, we keep it on the anterior side, on the left side. Now the heart is on the right side. So that means the current is going away from the leads. So instead of the R wave progressing, that is V1 having small R wave and by V6 R wave increasing in size, it is the reverse. So V1 will have a tall R wave and by V6 there will be a short R wave. So that is, there is a regression of the R waves in the chest leads. So if the limb lead shows reversal, that is L1 showing negative and AVR showing positive, and the R wave showing regression, then that is indicative of that this patient is having dextrocardia. So here if you see the chest leads seem to be normal, but only the limb lead there is a reversal. So that means it is a misplaced leads rather than dextrocardia. The next question which somebody had asked when we were talking about ECG and right ventricular hypertrophy, the question which was asked was, why can't this be just right ventricular hypertrophy which is producing? So it is not lead reversal nor is it dextrocardia, but it is right ventricular hypertrophy which is causing this tall R waves in AVR and negative waves in L1 and AVF. Why can't it be right ventricular hypertrophy? Anyone wants to tell that? Why can't it be RVH?
Sir, in V1 also there will be a positive R wave, sir. Uh,
Okay, so suppose the patient is having dextrocardia, then you'll have tall R waves in V1. So how will you differentiate a dextrocardia from right ventricular hypertrophy?
in the limb leads in 2, 3 ABF also there will be tall R waves.
Not necessary. So Vamshi mentioned AVR will not be positive in RVH. AVR will be positive in RVH. You can have a positive AVR in right ventricular hypertrophy. What is the most important clue for you to differentiate lead reversal or lead reversal from all other conditions, most of the other conditions? Axis can again be northwest axis, P waves. Yeah. So I think Sarishma and Vishnu mentioned. So P waves are the most important things here. You can see that in L1 the P wave is negative and in AVR the P wave is positive. Okay. So that indicates that it is actually lead misplacement or it has to be dextrocardia. It cannot be right ventricular hypertrophy. So any condition in which the right atrium is to the right and the left atrium is to the left, L1 will have a positive P wave and AVR will have a negative P wave. If you have L1 as negative and AVR is positive, that means the right and left reversal has occurred. Right atrium is now on the left side and left atrium is on the right side. So either it is dextrocardia or it is lead reversal. Those are the only two conditions in which you can have the P wave reversal. Otherwise, all other conditions, there is always the P waves which follow the conventional rule. That is, L1 is positive and AVR is negative. So is it clear for everybody? So when you have this type of a ECG where L1 is negative and AVR is positive, you have basically around three differential diagnoses, three important differential diagnosis. Okay, so the first, so the first common which is there is the lead reversal. Okay, so in lead reversal, what is happening? You are looking at L1. You are looking at, you're able to see the screen. So you are looking at L1. You are looking at AVR. So let's look at L1, AVR, V1 to V6. Okay. So now if it is a lead reversal, L1, the P wave is negative, QRS is negative. AVR, P wave is positive, AVR is positive. V1 to V6, there is normal R wave progression. Okay. Now if you have a dextrocardia, again P is negative, QR is negative, AVR, P is positive, and QR is positive. So it is almost equivalent to lead reversal, but there is a R wave regression. When you have a severe right ventricular forces which is producing it, then in this case, P wave is normal. So P wave is positive, QRS is positive, QRS is negative. AVR, P wave is positive, P wave is negative, and QRS is positive, okay? And R wave, again, regression is there. So based on the P wave, QRS complex, and the R wave, you decide whether it is dextrocardia, whether it is lead reversal, or it is predominantly right-sided forces, whatever the cause, right ventricular hypertrophy or left-sided forces are less, whatever the cause, you differentiate these three causes, okay? So is it clear for everyone? Sir, you want to add anything here?
Two things I just wanted to mention. See, suppose the lead reversal you imagine you corrected it here and put those leads in the places they should be. What is the diagnostic possibilities in this electrocardiogram?
Okay, what sir is trying to ask is, now this, of course, this patient ECG has been taken not to show you lead reversal, right? The patient had some problem. That's why ECG was taken, but the ECG by mistake they put lead reversal. So to show lead reversal we put. So suppose this was normal, that is what is in AVR is L1 and what is in L1 is actually AVR. Then what are the features in this particular ECG? That is, what are the abnormal features in this ECG? That's the reason why the patient probably came to the hospital and got admitted and got a ECG done, right? So what are the abnormal things which are there in this particular ECG? Can someone tell that? Okay, left axis deviation, poor R wave progression. Then what else?
Sir, in the chest leads V2 and V3, sir, the V2R is more than V3, and the RS ratio is less than 1 from V2 to V4, suggesting there is some chest lead misplacement also, I suppose. Like,
Yeah, so chest leads, actually one of the good practices is if you mark where exactly you are putting the chest leads and take the chest leads always in that position. Because one day one nurse will take in one position and another day another nurse will take in some other position. So that is something which can happen. But what other things are there here? V1, how are the P waves?
biphasic, sir.
Yeah, so biphasic P wave. Somebody mentioned already about left axis deviation. L2, you are able to see some T wave inversions and flattening in ABF. And then there are some, if you are able to see this is the T wave. And after the T wave, there is another wave here. What is this wave?
U wave, sir.
Yeah, U waves. And then there is some slight upsloping ST depressions in the chest leads. Okay, so those are all the findings which you can find here. So probably there's a possibility that this patient might be having hypokalemia or hypomagnesemia or something like that, in addition to a left atrial overload. Sir, you want to add anything?
Actually, ECG is not only lead reversal, but everything is badly done. But anyway, imagine this patient has a left axis. What is, say, the pattern of left axis or left anterior block can explain the poor R wave progression as well appearance in chest leads also. Left anterior block can have that pattern. But look at lead 2 and 3. In classic left anterior block, the S wave in lead 3 is always deeper than S wave in lead 2. Here, lead 2 has a deeper S wave than lead 3. This generally goes with some form of chest deformity. But this electrocardiogram is very poorly taken. Even chest leads, we have somebody pointed out is not done. Should be redone. But if that is true, look at the possibility of some form of chest deformity, rectus excavatum or say straight back, etc., can produce such deformities also, such electrocardiograms also.
Any questions on this ECG before we move forward?
Also, let them go and think about this patient has dextrocardia. If the leads are badly placed as it is done, what would be the appearances? Let them think about it.
Yeah. So I have a mental picture of what will happen. Suppose this patient actually has a dextrocardia and still the leads are placed very badly. What will happen? It is like double whammy. So dextrocardia, over that you are putting the leads in the wrong position. Okay, we'll go to the next ECG. Anyone wants to comment on this ECG? Anyone can volunteer. We'll just help you out in reading the ECG. You can start off in the normal protocol which we mentioned. Farhan, you want to start? Are you there, Farhan? Video is moving for others.
Yes.
Yeah, that's it is moving, Farhan. I don't know in your case why the ECG is not moving. Nagendra Prasad, would you like to read this ECG?
Sir, good morning, sir.
Morning, Prasad.
Sir, it is I cannot identify P wave, sir.
No. So go in order.
Sir.
Go in order of.
Standardized, sir.
Yeah, you say normal standardization. Okay? So
Yes, sir.
normally
Standardized.
Yes.
Tachycardia is there.
You have to tell the heart rate.
Probably 110.
Yeah, so it's around 12. 12 into 12 is around 144. So it comes to 1500 if you take. It's around 120 probably.
Yes, sir.
Okay. Then heart rates of 120. Then rhythm.
Maybe pre-excitation something.
No, don't jump to pre-excitation.
Okay.
What is the rhythm? Is it, do you have P wave followed by QRS complex?
No, sir. I am unable to identify P wave in any of the leads clearly.
No, why? These are all P waves. See, this is
Lead one is there.
Okay, so AVL you are not able to see properly. Some leads like V2, these leads we are not able to see properly. But you see in lead 2, lead 1, it is clearly seen. Okay. P wave followed by QRS complex, P wave followed by QRS complex. So if you see the rhythm strip, you can see P wave QRS, P wave QRS, P wave QRS. Okay.
Yes, sir.
What is the rhythm here?
Sinus rhythm.
Yeah, you should say sinus tachycardia.
Sinus
Because it's not normal sinus rhythm because heart rate's around 120. So it is a sinus tachycardia. Okay. After rate and rhythm, what is the next thing you take?
Axis.
Axis. So what is the axis here?
More towards 1, sir, lead 1. So probably 0 normal axis.
Yeah, one, it is a normal axis. If somebody asks you what exactly is the axis, probably it is L3, which is uh, equiphasic, still more negative than positive. But L3, once L3 is more equiphasic, that means it's around 30 degrees. Okay, so because it is more negative, it is between 0 and 30. So that's what you mentioned, that L1 is most positive. So it
Yes,
is
sir.
probably between 0 and 30 degrees. Okay, that's the axis. So it's a normal axis. Then
No. Then we'll go P, Q, R, S, and T.
P wave,
Um, P is normal in normal,
P
sir.
waves are normal. Okay, then
Normal. Um, there is a ST
no, we are not
depression.
going to ST still. So after P wave, what do you do?
QRS complex.
Now before QRS, what do you do?
PR interval.
PR interval. So what is the PR interval here? Take a lead where the big box, the P wave starts. So it's around 4 small squares. So
Normal, sir.
PR is how much?
2, 3 small boxes. So
4 small squares.
small size maybe.
So 4 into 40. So that is how much?
Yes. 0.16.
Yeah, 160 milliseconds. Okay, so that's normal. It's between 120 and 200. So it is normal PR interval.
Normal.
Then QRS complex.
QRS one.
So you look at the morphology, the duration of the QRS complex and the morphology of QRS complex. So is the duration normal?
Narrow to normal, sir. Narrow, sir.
Yeah, there won't be anything like narrow QRS. It's either
Narrow.
normal or broad.
Uh,
There won't be any condition which will narrow the QRS further. So it's either normal or it is broad. So it is the duration
normal.
is normal. Amplitude and all is normal. Any LVH, RVH, any bundle branch block, any pattern you are seeing abnormal Q waves anywhere.
No, sir.
So V2 you can see QS complexes. No? V1 and V probably there's a small R, but V2 looks like QS complexes. Okay, generally you should have slightly prominent R wave in V2. So it's a slightly, yeah, what you are getting is more of a QS complex in V2. So that is abnormal. Otherwise, there is no LVH, no RVH. Okay. Then
Okay.
after QRS complex,
ST segment.
so what does ST segment show?
ST segment there is in 3
So the way you read ST segment, it's like L1, L2, L3, ABF,
L3 depression is
V1, V2, V3, V4, V5, V6. So that's how you put it.
yes, sir.
Yeah.
2, 3 AVF there is a depression, sir.
Okay.
AVL there is elevation, ST elevation is there.
Okay.
And V2, V2, V3 also slight elevation is there, sir.
Yeah, looks like some that STs tend to be going up, though this ST elevation is obvious. Here it appears as if the STs are going up, V1 to V3. Okay.
Yes. Again, V5, V6 there is depression.
V5, V6, there is ST depression. Okay. Next.
T wave, sir.
Yeah. So what do T wave show? Again, follow the same thing. L1, L2, L3, AVR, AVL, AVF, V1 to V6. L1 T wave is normal.
L1 is normal, sir. T wave is L1 T wave is okay, sir.
Probably there is a T wave inversion. Okay. L3, because of the ST, there is confusion, but L2, L3, it appears as if T wave is flipped. It is inverted. AVR, AVL, it's okay. AVF, again, it appears as if it is flipped. Okay. V1 to V6, T wave appears almost normal. Agreed?
Yes, sir.
Okay. QT interval?
Normal, sir. And
Less
should
than
be taken.
50%, yeah, less than 50% of RR interval. Okay.
Okay.
So The reason why I took you through all these things is just to show you that if you don't repeatedly practice writing down the ECG in all the 9 or 10 aspects of it, you will tend to miss a lot of things. So it has to become part of your character. It should go into your subconscious mind. The moment you see ECG, you are looking at everything. Your mind should rate rhythm, axis, P wave, PR interval, QRS complex, ST segment, T wave, QT interval. It should come in your mind. The moment you see the ECG, you have to go through that. If it doesn't, unless you practice, you saw how much difficult it was that after P wave suddenly you jump to ST, then again come back. So unless you practice, you are not going to achieve this perfection in reading the ECG. So you should repeatedly do that. So after you have explained the ECG, can you tell us the ECG diagnosis, Prasad? What does this ECG show?
Anterior infection is there, sir.
What is
Anterior wall.
anterior wall what infarction? Is it non-ST elevation or ST elevation?
ST elevation is there, sir.
So you should mention that there is an anterior wall and lateral wall ST elevation MI. Okay. So it's
Okay, sir.
important. Now, see, previously the reason why we put this ECG is for you to understand the change in concept from what it was before to now. Previously, always it used to be called as Q wave MI, non-Q wave MI, but Q waves take a long time to develop. Now the ECG today is your diagnostic tool to tell what you are going to do with the patient. So a patient comes to you and you have ST elevation in MI, the ECG, then you follow the ST elevation MI protocol. So you take the patient, give thrombolysis, or take the patient for primary angioplasty, or do a pharmacoinvasive therapy. That is the protocol you follow. You don't have ST elevation, you have only ST depression, then you follow a unstable angina or a NSTEMI protocol. So this is an acute thing. You can't wait till troponin also. Your troponin will take about 2-3 hours to come. But here you want to achieve a revascularization in less than 90 minutes. So for that, the moment you see the ECG, you divide it into STEMI or NSTEM. So this ECG is suggestive of a ST elevation MI, and this patient needs to be taken up for the primary angioplasty or give thrombolysis if the patient is within window period. So the next question to you is, Prasad, the patient also has ST depressions in inferior leads. So what is the significance of that?
Yeah, there may be reciprocal changes, sir.
Okay, so first is that they are reciprocal changes. So anterior wall, now you are having a situation where the current of injury is on the anterior wall. So when the current of injury is on the anterior wall, the inferior wall will show ST depressions. So that is reciprocal changes. Similarly, if patient has ST elevation in inferior leads, you can have ST depressions in the anterior leads. What other significance of ST depressions? Anyone else wants to answer that? When you have a patient with STEMI and you have reciprocal ST depressions, what are the important things you want to know about those ST depressions? Ashish, you want to answer that?
Sir, can you repeat the question, sir?
The question is, now this patient has anterior wall ST elevation, and then you have reciprocal ST depressions in inferior leads, L2, L3, AVF. So I asked Prasad, what is the significance? One of the things he said is it's reciprocal changes. So patient has anterior STEMI and patient has reciprocal changes. What other things it might indicate?
Yes, sir. As he told, like it is indicative of it is myocardial infarction with the reciprocal changes are there. Again, sir, it can be inferior wall NSTEMI also possible, sir.
The second possibility is there is an inferior wall ischemia. So there are two areas which are having ischemia. So one is anterior wall has developed STEMI and inferior wall is developing ischemia. What other thing? The other important thing you should remember is ischemia at a distance. So that means now say the patient has LAD and that is supplying the right coronary artery. Now LAD has got occluded. So one, it is infarcted the LAD segment and it has also reduced the blood supply by collaterals to the right coronary artery. So that area has become ischemic. So one, it's just reciprocal changes. Two, it is ischemia at a distance. Three, it is more than one territory where the patient is having ischemia. Generally, a patient who has a STEMI with reciprocal changes, they have a slightly worse prognosis than people who do not have reciprocal changes. Okay, so that it has some significance. The next question is, why can't this be inferior wall ischemia and reciprocal ST elevations in anterior lobes? You only told us that there can be reciprocal changes. So why can't this be inferior wall ischemia? Such deep ST depressions are there, and all the ST elevations are reciprocal changes. Prasad, any comments on that?
No, sir. No idea.
Ashish?
Sir, always when the ST elevation and depression present at the same time, main like driving predominant will be the ST elevation step. Like the vector will be important. The important significant will be the ST elevation, sir. It's more prominent. What I can say, like stronger vector. I cannot put in the words.
No, the basic vector is always the ST elevation vector. Okay, so when you have ST elevation and you have ST depression, always the predominant, the actual vector is the ST elevation vector, and it's the reciprocal changes which produce ST depressions. It doesn't happen the other way around. Okay?
Yes, sir.
Because of what we explained to you, how ST depression occurs and how ST elevation occurs. So if you have a subendocardial ischemia and the injury of current is going away from the lead, that actually doesn't produce ST elevation, right? It's not enough to produce ST elevation. So always when you have ST elevation and ST depression, it's always ST elevation which is the primary abnormality, and ST depression are the reciprocal changes. Okay. Any doubts or any questions on this? So here you saw a case of anterior wall ST elevation MI with lateral wall. So maybe R also there is ST elevation. You saw the reciprocal changes and the significance of identifying STEMI, as well as the significance of reciprocal changes in a ECG when the patient has a ST elevation MI. Any questions on this? Sir, you want to add anything?
Originally, few decades ago, these were all interpreted as reciprocal changes, not much importance was given. But as more and more angiographic information is available, primary angioplasties are done. Now, as is already pointed out, the reciprocal changes may indicate ischemia in a remote territory. Typically, this is published for an inferior MI, the anterior wall reciprocal changes. So inferior MI has a significant anterior wall reciprocal changes. Most of them had LAD significant lesion. So it can happen to other examples also, other MIs also. So the importance of this in management of the patient is, if reciprocal changes are so significant, when you do an angiogram in an acute MI situation, a primary PCI, this also may become an indication for angioplasty to non-infarcted vessel. That may be used as a clue, the importance of it. And some of these patients will have, say, suppose they have isolated inferior MI. Generally, they don't have, unless they have heart block or other things, they are not in shock and all that unless they are RVMI or heart block. So if a patient with inferior MI, what looks like small, has serious hemodynamic problem, the other ischemia in remote territory is responsible for valve dysfunction. So all this has importance. Thank you.
Hope everybody is able to understand or follow the thought process. Anyone has any questions or anyone has not understood? It's clear? Okay. So who would like to take this ECG? Just unmute and start reading. Someone wanted repetition of STEMI with reciprocal changes. So whenever you have ST elevation in one leads, the opposite side leads will show ST depression. It is just normal physics. So if current is going in one direction and the leads are in the opposite direction, one area, if it is producing ST elevation, the opposite side will produce ST depression. So those are referred to as reciprocal changes. As sir mentioned previously, the reciprocal changes were considered to be benign. That means it doesn't matter whether patient has reciprocal changes or doesn't have reciprocal changes. But now we know that when you have reciprocal changes, one, it could be just because of the normal phenomena of the current. Two, it can occur because there is a ischemia at a distance. That means, say, now RCA, right coronary artery, has produced an inferior wall STEMI, and then that has produced a ST elevation there. And the blood is now supplying the LAD, which also has a tight stenosis. So when this gets occluded and that area is ischemic, then you can have ST depressions in the anterior lead. So reciprocal changes could be just pure reciprocal changes, or it could be ischemia at a distance, or it can be ischemia at more than one territory. So that's what was mentioned. Is it clear, Binit, now? Okay, so we'll move on with this. So there is one ID which is SIR, SIR. So can you just identify yourself and can you help us in reading this ECG?
So good morning, sir.
Good morning.
This is of normal standardization.
Can you just introduce yourself, madam?
Myself, Sirisha, sir, from Pratima Institute of Medical Sciences. MD
Okay.
final year.
Final year of MBBS?
MD final year, sir.
MD General Medicine. Okay.
In MD General Medicine. Yes.
You're Sirisha.
Yes, sir.
Okay. Okay. Go ahead, Sirisha.
This is of normal standardization, sir. Rate is of 103 boxes, sir. 300 by 300. Heart rate is 100. Rhythm is normal sinus rhythm. Left axis deviation is there, sir. Coming to the P waves, right atrial enlargement is seen. P pulmonary pattern is seen in the P waves in lead 2. Coming to PR interval, it is of normal PR interval, sir, 120 milliseconds.
P wave, what did you mention? Can you tell us what is the approximate axis here?
Approximate, it is LAD is there, sir.
Which is the most equiphasic wave here?
1 and AVF.
Equiphasic. Equiphasic is AVF.
Yes, sir.
Okay, so equiphasic AVF is almost 0 degrees. L3 is also equiphasic.
Almost equiphasic.
So that will come to around 30 degrees.
30 degrees.
And so L2 again is kind of equiphasic. So L2, L3 and AVF, all three are near equiphasic leads. No obvious left axis deviation. AVL still continues to be, though there is a small Q wave, and then it is predominantly positive AVL. So probably L3 is more negative, and L2 is almost practically equiphasic. So it is between kind of L2 and AVF. 0 degrees and probably minus 30 degrees somewhere there. Okay. P wave, what did you mention?
Right atrial enlargement, sir. P pulmonary is seen, sir.
So P pulmonale, this won't fit into the criteria of P pulmonale because at least it should be 2.5 mm. Though the morphology, if you see, it looks slightly peaked compared to normal, but the height also should be more. So it doesn't fit into the criteria of P pulmonale. But V1, what do you think?
Low voltage complexes in
No, the P wave, what do you think?
it's a inverted P waves biphasic in P1, sir.
So what does that indicate? So this satisfies the Morris index. So it indicates a left atrial overload pattern. Okay, so if you see the width and depth, it is more than one small square. So here it's more suggestive of a left atrial overload pattern. Okay. So P wave
Coming
is
to PR,
suggestive of LAO. Okay, then
coming to PR interval, it is almost 120 milliseconds, sir.
so it's normal.
Normal PR interval. Coming to QRS complexes, sir, there is ST elevation in
No, QRS, you don't tell ST elevation. You talk about only the
normal
QRS.
normal QRS, sir. No broadening and this thing, no deep S waves in V1.
So is
Normal
it S wave or is it Q wave?
It is S only, sir. Small R can be seen.
Where are you able to see R? There is no R wave. R
ST
wave should have a positive deflection. You can see that from the baseline it is going down. From baseline going down. From baseline going down. So there is no R wave here. So these are all Q waves. Okay, V1, V2, V3,
complexes.
V4. Okay, so this is QR. Okay, you have QR complexes V1, V2, V3. Okay. So
QR
that is
complex.
abnormal. So QR complexes from V1 to V4, that is abnormal here. Okay, then next.
Coming to ST segment, sir. ST segment elevations in lead 2, 3 and lead 2 and 3, sir.
Where do you see ST elevations in lead 2 and 3? 2 and 3 is almost flat here.
So
Some
V1,
ST depression side.
V2, V3, sir. ST elevation.
Chest leads you are telling. Okay.
Chest leads, yes.
Yeah.
In chest leads, V2 and V3. And T
V4?
inversions in V4
No,
and
ST
V5.
elevations in V4.
Yes, sir. V4 also ST elevation is there, sir.
V5.
No, sir.
Yeah, they are ST elevations. No? You can see this coving, that is ST elevation.
Concave coving, okay.
Yeah. AVL.
AVL also ST elevation is there. Elevations in AVL.
So almost there are ST elevations from V1 to V5, probably L1 and AVL also. Okay.
Wave inversions in chest leads 4, 5 and 6. And QT interval is normal. ECG suggestive of anterolateral.
1 minute. How do you say QT interval is normal?
It is half of RR, sir.
So this is
Less than half
R
of R.
interval. This is half. So at least on eyeballing, this seems to be more than half of RR interval. So how much is this? This is 5. Okay, then this is another 3. Okay, 8. So 8 into 0.4 is 0.32.
0.32.
Okay, 0.32. Then we are just calculating to see whether it's really prolonged or not. So now this is 5, 10, 15. 15 into 4 is 0.6.
0.6.
Okay, 0.32. Square root of 0.6 will be 0.8. 0.8 will be 0.64. So slightly less than that, probably around 0.77 or something like that. So 32 divided by 0.8 itself will go up to 400 milliseconds.
400 milliseconds.
So if it comes down, then it will come to around 420, 440 milliseconds. So it's borderline QT prolongation here. At least by rule of thumb, if you see, you can see that the QT is prolonged. Okay, it's more than 50% of RR interval. Okay, so this is the RR interval, and it seems to be more than 50% of the, just reaching or crossing 50% of the RR interval. Okay. Then what else?
Coming to the diagnosis, sir.
We have not finished reading the ECG. Anything else is there abnormal?
AVR is positive, sir.
AVR is not positive, AVR is
Yeah,
negative.
not net positive, but it's slightly positive.
That's okay.
This LVH, sir.
What is that? There's no evidence of LVH as such. Probably V3 you're telling. 5, 5,
V2.
10, 15, 20. Okay.
20.
Probably it's just crossing 20, but in V1, V2 it is not there, V5, V6 it is not there. Probably some suspicion here. Any other abnormality in this ECG?
Ventricular premature complexes, sir, in
Very good.
V4, V5, V6.
Yeah, the patient has VPCs. Okay. So is it important or not important?
These are important.
Why?
Ectopics are emerging from the ventricles.
The patient has ectopics and suddenly this patient can throw a VT, VF or something. So identification of VPCs is again important. Also look at any electrolyte abnormalities in this particular patient. Now, so what is your full diagnosis in this patient?
Anterolateral or ST elevation MI with with no reciprocal changes.
So you tell only the positive things when you are talking about the
Anterolateral wall MI with anterolateral wall MI with ST elevation MIs.
what else is there? Left atrial
Slightly,
overload you mentioned.
yes, sir, left atrial overload.
VPCs you mentioned.
Yes. VPCs and left atrial overload.
Okay. So again, to emphasize how difficult it is to get into this habit unless you keep practicing. So for every ECG, you tend to miss. What is obvious, you'll be able to pick up. But then there are certain abnormalities of ECG where things are not obvious. And there, when you don't follow this process, you'll tend to miss. So both reading the ECG as well as writing the diagnosis of ECG, extremely important for you to practice repeatedly. So once you keep doing it for multiple cases, then it becomes easy. So now here you think it is a evolved anterior wall MI or do you think it is a acute anterior wall?
Evolved T inversions are established, so it is an evolved anterior wall MI.
What else? Q waves, right? So you
Yes,
have
Q
deep
waves,
Q
long,
waves
deep
and
Q
then you
waves
have
in
T's which are
V2.
inverted. So generally it indicates that probably this patient has a evolved anterior wall MI. Still, if the patient says, if you take the history, what is most important in window period, irrespective of the ECG, is the time of onset of pain. If the patient has been having on and off pain or stuttering pain, what was the time at which he had the maximum pain? So all those things you still need to take into consideration. So just don't, based on ECG, don't deprive the patient of primary angioplasty or whatever is the treatment which is necessary. So
Okay.
ask the patient repeatedly. Suppose the same ECG is there, but he says, just 4 hours back I had pain and still I am having some uneasiness. So don't say that this is evolved anterior wall MI on ECG, so I will not do anything. Most of the times, this ECG you will find if the patient had pain about 2 days back or 3 days back and now has come to you to find out why exactly he had that pain about 3 days back. Then it's different. Then you don't rush with angiogram or primary angioplasty. So the clinical situation of the patient is extremely important because a lot of fallacies can occur just based on the ECG. Something which is acute, you might mistake it for evolved. Something which is evolved, you might mistake it for acute. So multiple mistakes can occur when you are uh, uh, going ahead and then trying to diagnose just the timing just based on ECG. So you should not fall into the trap. Okay. Now say this patient had MI about uh, about 4 days back, and this is
Okay.
the ECG. What are the possibilities which exist for these persistent ST elevations?
Maybe acute onset.
One is evolved anterior wall MI you mentioned. Okay.
Yes.
Then
Superadded acute attack, maybe there's.
re-MI. So that means patient had MI, ST settled down and now again had re-MI. because of which the STs have again gone up. Okay, then.
And
Anyone else also can answer. It's not necessary that only Sirisha should keep answering. So Amir mentioned apical aneurysm. Okay, so a dyskinetic segment. Apical aneurysm can produce persistent ST elevations. What else? So re-MI, non-revascularized MI, LV aneurysm, and then, so Ashish mentioned pericarditis. Okay, so that is the differential diagnosis of persistent ST elevations. So a patient had MI previously and now comes with persistent ST elevations. Those are the things which you should look into. Now, why is this important? Because your management strategies change based on this. If it is a re-MI, patient is having chest pain, that's a situation where probably you might want to look at the angiogram and open up the vessel. Patient has a post-MI pericarditis, that's a contraindication for you to do angiogram. Because you give heparin or you give high doses of antiplatelets, the patient can have bleed into the pericardium and go into tamponade, or patient can develop a cardiac rupture. So that can be, so patient would have been better off without coming to you. Post-MI pericarditis, you do all these things, patient can, you might increase the chances of cardiac rupture. Suppose if it is a apical aneurysm, that means it is already evolved. There you do angiogram and vessel is blocked. There's no point in trying to do angioplasty or anything because it's not going to change the outcome. Trials have shown that once a LV aneurysm has developed and you open up the vessel, more people die when you open up the vessel than when you don't open up the vessel. That means stenting is more counterproductive to the patient than not doing any stenting. So first, thinking about these possibilities when the patient has persistent ST elevation, then finding out what is producing this persistent ST elevation, and based on that, planning the management strategy. So that's the importance of just a small, simple ST elevation with Q waves in a patient who has come to you after about, say, 3 or 4 days. Okay, is that clear? Any questions on this? VPCs will come to later, how we differentiate a VPC from supraventricular rectal. Sir, you want to add anything?
See, continuing on what you said about the ST elevation, also note that if it is already a completed MI, so-called, after a few days, the persistent ST elevation, even in L1 AVL, apart from other leads, with hardly any significant T wave inversion, is a dangerous sign. It is a sign of regional pericarditis and impending rupture. This patient needs an MRI, etc.
Yes, sir. So any more questions about this ECG? Tomorrow we won't have class. I'm not there in town, so we'll continue on Saturday. Read about heart blocks and tachycardia for Saturday's class. So we'll discuss about, we'll show you some ECGs with heart block and ECGs with tachycardia and how we differentiate. If we have time, we'll go to tachycardias also, how we differentiate the different types of heart block and the different types of tachycardia. Any questions on what we discussed today? So about 3 ECGs we discussed today. Anyone has any doubts or any repetition, any clarifications you require? So if there are no other questions, I think we'll close the session for today. Sir, shall we stop now?
Yeah, we can stop.
Yeah. We'll continue on Saturdays. Narasimha, you can close the session.